So what are the risks or potential risks of Ozempic?
Okay, so let me tell you briefly again the insulin story. Remember, type 1 diabetics, patients with type 1 diabetes need insulin to survive. So when insulin is first isolated from the pancreases in 1921 at the University of Toronto, and then early 1922, it's first used experimentally on human patients. It's a lifesaver. It's a wonder drug. It's the first miracle drug. You have these patients who are at the brink of death. You give them insulin, which is what they're missing. You bring them back to life. Okay, so until then, the way to treat this disease was you can't metabolize carbohydrates, don't eat them. Now you have a drug that can treat the disease. And on top of that, the drug actually creates the condition of hypoglycemia. It's so good at controlling insulin and so difficult to dose properly that it causes low blood sugar, which can be immediately fatal or quickly fatal. So the lack of insulin will kill you over weeks to months to year. Too much insulin, very low blood sugar, can kill you in 12 hours. So doctors respond by telling their patients they have to eat carbohydrates to balance the insulin. This is what I meant by you now design the diet to fit the drug therapy, as opposed to designing the drug therapy to fit somebody who's maximizing dietary therapy. Through the 1920s, doctors realized that their patients aren't following their diet advice anyway, so let's let them eat whatever they want and give them whatever insulin is necessary to cover the carbohydrates that they're going to eat. And particularly with children, they're diagnosed with this very scary disease that's significantly going to shorten their lives even with insulin. Do you really want to tell them they can't have an ice cream cone ever again, or they can't eat birthday cake ever again? So you let them eat those foods and you give them insulin, and it spreads from children to adults. This would all be fine. But by the 1930s, a diabetes specialist realized that they're in the midst of a new kind of epidemic, very similar to what we've been experiencing over the past 50 years in everyone. So these young patients who they had kept alive with insulin are now manifesting all the sort of long-term consequences of living with diabetes. So arteriosclerosis, which is basically, atherosclerosis, but in every vein and artery in their body. They're having heart disease, strokes, they're going blind, retinopathies, neuropathies, which is nerve damage, and so they're amputations. And when you read the case studies of these kids who are now in their 20s, early 30s, a wonderful book written by a University of Pennsylvania pediatrician, medical historian, and medical ethicist named Chris Feutner called Bittersweet. What's so striking about it is these kids stayed healthy. So the insulin saves their lives. It's a wonder drug. They thrive for like 10, 15 years, and then their bodies tend to fall apart over the course of a year or two. Reading the case studies is heartbreaking. And it made me a little bit nervous about the ketogenic diet also, because as you pointed out, we only have long-term evidence for, clinical trials for 5 years. So the question is, what happens after 15 or 20 years? And then the other aspect of my book that I describe historically is all the misconceptions the diabetes community created about diabetes as a disorder, because they were responding only to how drug therapy was controlling the disease and the devices they had. And so as soon as they had insulin, it changed how they thought about the disease. Suddenly diabetes became an insulin deficiency disease because it could be controlled by adding insulin. And all these other nuances of the science got pushed aside. So now Ozempic comes along. It's a wonder drug. Undeniably does. A drug that can significantly reduce the weight in patients who struggle with obesity is an amazing thing. But like insulin, patients are going to be on it for the rest of their lives. Like insulin, if they go off it, bad things are going to happen, although they may not be as fatal as a patient with type 1 diabetes going off his or her insulin. And we have no idea what the long-term consequences are. So Ozempic itself, or the variations of these glucagon-like peptide 1 agonist, receptor agonist drugs, have been tested for out to 3 to 7 years, but we don't know what's going to happen afterwards. And like insulin, already we see the American Academy of Pediatricians, for instance, promoting these drugs for adolescents struggling with obesity. And, the psychological burden of living with obesity for adolescents is terrible. And I understand that. But these are kids who are going to be on this drug for 20, 30, 50 years. And you have no idea of the long-term risks and benefits. And we won't learn it until they've been on the drug and we start seeing. And when I first tweeted about my Atlantic article, I said, this drug scares me because it's a wonder drug, because it's so effective. And I worry about the long-term risks, and I hope I'm wrong.
So I want to explore this connection or the analogy between insulin and Ozempic, and specifically, I want to understand what's so bad about insulin, because it's a miracle. You said it's a miracle drug; it saves lives, and yeah, there can be adverse side effects down the road, but certainly the benefit seems to outweigh the effects. You wrote that insulin therapy might be responsible, at least in part, for diabetic complications, and I can't pronounce this word, atherosclerosis and high blood pressure. So I guess, what my question is, isn't insulin totally worth it despite these potential complications?
Well, it's not just insulin, it's how you use the insulin. So again, when insulin was first introduced as a therapy in 1922, the thinking, which was dominated by one clinician, Elliot Jocelyn, who had opened the first diabetes clinic and the dedicated diabetes clinic in the US. Today, his clinic has become the Jocelyn Diabetes Center at Harvard. So his thinking was, this is a very dangerous drug. So let's minimize its use and maximize the use of diet to control the disease, which makes an enormous amount of sense. So you remember, there are always two ways to control blood sugar, two significant, the first order ways to control it are drugs or diet. So with diet, we could be fairly confident that we're not doing harm, fairly confident, not completely confident. And with drugs, we have no idea because there's always risks and benefits. So as I said, as this period went along, other people argued, look, this drug is so powerful, just let people eat what they want. And Jocelyn eventually went along with it well. So by the time they started manifesting the complications of the disorder in the 1920s, 1930s, and you see this tidal wave of diabetic complications, which is how it was described, you have no idea what's causing it. So remember, they didn't do clinical trials until the late 1940s. So it could be the long-term consequences of living with diabetes, because these patients with type 1 never lived more than 2 or 3 years after diagnosis. So it could be unavoidable. And that's what the people pushing for these liberal diets argued. It could be that they weren't doing as good enough a job controlling their blood sugar, which is what Jocelyn was arguing. So you wanted more intensive insulin therapy, better in tuned with the diet, and the diet better tuned to the insulin therapy. It could be the insulin therapy as well. Endocrine diseases, endocrinology is a science of hormone. Hormonal diseases are defined not just by having too little of the hormone, but by having too much of the hormone. There's hypothyroidism and hyperthyroidism. And diabetes books will endocrine textbooks will discuss them both. We've always known that too much of a hormone is as bad as too little, or can be bad in its own ways, or worse. Because of the way the field developed, they never got a chance to understand that. So the other aspect is type 2 diabetic, patients with type 2 diabetes don't need insulin. Their problem is not a lack of insulin, it's a resistance to the insulin that's being secreted. And because their cells are resistant to insulin, the pancreas responds by secreting more of it. So they're actually have too much insulin in their bloodstream rather than too little. Those people also got insulin. So now you have a disorder of too much insulin, and you treat it by giving more insulin, which some people today will describe as throwing gasoline on a fire to put it out. This has been the standard of care for decades. So another way to look at it, instead of diagnose, and again, you can't blame the doctors because they just didn't know these things. And by the time they found out, so insulin's discovered in 1921, arguably it's not until 40 years later, 1960, that they begin to learn that 95% of their cases are not insulin deficient, they're insulin resistant. Those are the patients with type 2. But by now they've locked in their thinking about how to treat the disease. And it takes 10 to 15 years for this understanding of insulin, arguably 25 years, before physicians really, the message is really disseminated that type 2 diabetes is a disorder of insulin resistance, not insulin deficiency. And that's 25 more years where the doctors have locked in their thinking about how to treat the disease. So this is what I mean is,
doesn't insulin extend the life of someone with type 2 diabetes?
Not necessarily. That's what's so fascinating. So then the other issue, and as I discuss in the book, the diabetes community gets far more credit than the obesity community in this sense, is that they were willing to do some very ambitious, long, expensive clinical trials to test their hypotheses. So for instance, one of their hypotheses is giving intensive insulin therapy to patients with type 1 diabetes would minimize the complications, lessen the complications. That was a study called the Diabetes Control and Complications Trial in the 1980s. Nationwide study, it showed that it did indeed lessen complications somewhat, but at a price of creating more hypoglycemic episodes and at the price of creating weight gain, which would make these patients more susceptible to these other complications of the disease. As these diabetes specialists did these large, ambitious trials, they basically refuted all their beliefs. So for instance, in the 2000s, there was a series of 3 trials, the Accord trial, I'm going to forget their names, the Veterans Administration Diabetes trial, and I forget the third one, that were testing the idea that intensive insulin therapy in patients with type 2 diabetes would have fewer complications. And instead, it turned out that they died more frequently, that it lessened their life rather than. But again, one of the problems with medical science is medical establishment is if you believe something throughout your entire career, it's very hard to accept the message of a clinical trial telling you that your belief system was wrong. So by the 2000s, the accepted wisdom about both type 1 and type 2 diabetes is it is a chronic degenerative disease, progressive disease. So by that it means the drugs aren't going to cure it, and it's going to continue to get worse. So you're going to continue to have to add new drugs or increase the doses. And I quote in the introduction to the book a 2017 American Diabetes Association report in which the doctors said, the biggest barrier to successful treatment of this disease is the hesitancy of physicians, the inertia, they call it physician inertia, to continue prescribing new drugs in higher doses. And meanwhile, the complications of the disease, the blindness, the amputations and nerve damage, the heart disease, that you have no idea if that's better or worse than it would be without insulin therapy, but with diet therapy, because that's wasn't tested until, again, beginning in the early 2000s. So for type 1 diabetes, insulin will keep those patients alive. It's a wonder drug. It's absolutely a necessity. For type 2, it could be a terrible mistake. And type 2 patients are 95% of the patients with 90 to 95% of the patients.
I mean, and obviously it's best if people can have a good diet and healthy diet and exercise, of course. I mean, that recommendation goes for everyone. For type 2 patients with type 2 diabetes, my understanding was that, yeah, if they can improve their diet, that's great. But if they can't, or if diet's not enough, that the diabetes, that insulin, despite the potential harms, ultimately does allow those people to live longer. But what you're saying is that that's not the case. Like if you have type 2 diabetes, your lifespan is not prolonged with insulin.
No, at this point in time, if you're diagnosed with diabetes, your prognosis is better than ever before in history. That's undeniable, and particularly
Because of insulin. Because of
not
insulin, right?
with type 2. It's not necessarily because of insulin. Actually,
Then,
again, one of the
then what's the reason? What's the reason then?
there are these other drugs, GLP-1 agonists, are,
Right.
for type 2 diabetes. They appear to be very effective drugs. Hopefully, they'll replace insulin as therapy. The issue is, you said if the diet isn't enough. And so the argument I'm making in the book, one of the arguments is the diet was never tested. So once insulin was discovered, that locked in the idea that patients could eat their carbohydrates, basically have their cake and eat it too, and insulin will cover any necessary problems with the diet. And if you're not controlling your blood sugar, you don't change the diet, you just try and change the insulin dosing, and new insulins were discovered, longer lasting insulins, slower acting insulins. There was always a new drug in the pipeline that could allow you to control your blood sugar without having to worry about the diet. And then in the 1960s, and this was a story I told in the second science investigation I did, and in my first book, Good Calories, Bad Calories, we embraced this idea that saturated fat and high fat diets were the primary cause of heart disease. And so became the definition of a healthy diet, became a low-fat diet rich in fruits and vegetables. And this became the diet that was prescribed for diabetic patients. So the idea was, in healthy patients, in non-diabetic individuals, we get heart disease because of the saturated fat content of our diets. And so we should eat low-fat diets. And patients with diabetes get heart disease because of the uncontrolled blood sugar. That's why their heart disease risk is increased. But they could mitigate that risk by also eating low-fat diets, even though low-fat diets are high in carbohydrates. So you're basically trading off cholesterol control for blood sugar control. In a population in which you know that the reason they get diabetes, they're at an increased risk, is because of their poorly controlled blood sugar and perhaps their poorly controlled insulin, which you don't know for sure one way or the other. So you really just don't know. In the first major clinical trial that was done in the 1960s was done to test the first oral blood sugar lowering agent, Taubes. It was a pill you could take by mouth that would lower blood sugar. There was a congressman whose niece had been diagnosed with type 1 diabetes, or with diabetes period, and she was prescribed Taubes, and this congressman asked a local diabetes specialist in Cleveland whether or not Taubes would make her healthy, and he said, we have no idea. So the congressman helped him raise money to do a clinical trial, and it turned out that not only did Taubes not extend the lives of these patients or reduce complications of the disease more so than diet alone, insulin was also tested, and the insulin didn't benefit. And the community responded by assuming we must have done the trial incorrectly, which is always possible. Although if it had gotten the results they expected, they would not have said that. But
to be clear though, like, and as far as it pertains to Ozempic, like there's no known risks or downsides to Ozempic. You're speculating that there could be, maybe, right?
yes, I am speculating that there could be maybe, and it makes me nervous.
But maybe there's not.
And maybe there's not. Well, again, and we talked about this before we got on the air, but very well, what a story that could be an analogy to this is the benzodiazepine story for anxiety, depression, insomnia. So these are very, Klonopin is one of the most famous drugs in this category. I always forget if Ambien is part of this category. Xanax is, Valium. And these are drugs that, for people who suffer, for instance, from insomnia, are wonder drugs. You take Klonopin, you sleep. So originally, and I remember when Ambien was first prescribed, it was you would get a 2-week supply from your doctor, and that was it. Because they didn't know you were supposed to retrain your body to sleep over 2 weeks, and they wouldn't give any more. But then you slowly think, okay, this is benign. We could give it for as long as people need it. It got easier and easier to get long-term prescriptions. And you get to the point where people have been on these drugs for 20 years. And then but eventually our bodies get used to drugs. So if you're not addressing the underlying cause, a likelihood is that you will either need higher doses, as is when you think of a disorder as a progressive disorder like diabetes, or you start having side effects that you might not have had when you were younger. The journalist Robert Whitaker, you should have him on your show. He's in Boston. He wrote a couple of tremendous books on this subject, Anatomy of an Epidemic and Mad in America, and started a website. And it's all about basically what happens after 10 or 20 years on these drugs and the damage they could do. It's a mirror of the insulin story in diabetes. And again, it's one of the issues with journalists doing these stories like myself and Bob Whitaker is it's easy after a while to sort of put us in a corner and forget about us. We're one voice saying, and it's a Cassandra-like voice saying, whoa, wait a minute, just slow down here. Because you're not giving this drug it's not like taking, I don't know, an antibiotic for.
But don't some people need drugs? Like sometimes you need, a medicine, even though it might have side effects. Like
I said, the problem with these drugs is they're wonder drugs. They're so effective. I mean, I probably know.
Aren't there cases where you need to have a certain medicine?
Absolutely,
insulin. So maybe some people need Ozempic because if they don't get it, then they're going to die.
I know people who I think Ozempic is an amazing drug. They're not going to. Well, again, obesity associates with all kinds of chronic diseases. It's an open question whether it. Morbid obesity is I think it's a terrible burden. The fat acceptance movement probably would prefer I don't phrase it like that. The very complicated situation. The question is always, when you're putting somebody on a powerful drug for life, an expensive, powerful drug for life. Let's take an extreme example. Say we have a girl who's 16-year-old and suffers from obesity, and diet has not helped her, and diet is a burden for everyone, whether it works or not. And so she's put on Ozempic and she loses 50 pounds. And now 10 years later, she's happily married and wants to get pregnant. Okay, this is probably the scenario that worries me the most. I don't think we have any idea what Ozempic does during pregnancy to the fetus, to the child. Maybe I'm wrong about that. I hope I'm wrong about that. And it's very well understood from animal studies. But a likely scenario is that the woman wants to get off. If she tries to get off the drug when she's pregnant, she's going to be gaining weight back while she's pregnant. We know that excessive weight gain during pregnancy comes with all kinds of long-term complications for the child. It's a scenario known as fetal programming, and the child will
Is it dangerous to be pregnant while on Ozempic?
We don't know. But we also know that if the doctor says, okay, if you're planning on getting pregnant, you should go off the Ozempic. Now she's going to be gaining weight when she gets pregnant. And we know that they're very complex situations. I don't know what the answers are, and I hope I'm wrong. Because I can imagine Cassandra, in the Troy going through a life going, geez, I wish I'm wrong about this, but don't let the horse.
I mean, there's a lot of
in
stuff we
the,
could worry about, but without evidence, I mean, I could worry a meteor is going to hit the world, but if we don't have evidence that Ozempic is harmful for pregnant women, why are we spending time worrying about it?
I'm just raising the possibility that it's something you should know about, because at some point people are going to be wanting. I mean, it's assuredly already happened. And again, you have to, as I say, context is everything in these things. So my context is in writing the diabetes book is, like I said, if insulin is a legitimate analogy, then the problem with insulin, again, it was a wonder drug. But people in the 1920s saying, why worry about it? It's keeping these people alive. Let them eat what they want. And that turned out to be a tremendous mistake. Let me give you a different way to think about it, again, based on diabetes. So this was a story that was told to me by a journalist who was he was a chef who became a journalist, was diagnosed with type 1 diabetes in his mid-30s. When you're diagnosed with diabetes, most of us don't give it a lot of thought. So you're diagnosed with the disease, suddenly you're sort of dumped into disease land. Like I think of the carnival games where you throw the baseball, and if you hit the target, the person plunges into the water. Well, that person is what happens when you're diagnosed with these diseases. So suddenly you're trying to learn as much about it as you can while you're simultaneously coping with the existential terror of the disease. And so his doctor says to him, look, this is the problem. You don't secrete enough insulin. You have an insulin deficiency disorder. As a result, you cannot metabolize the carbohydrates in your diet safely. So what we're going to do is we're going to have you eat so many carbohydrates for breakfast, lunch, and dinner, and then we're going to you're going to dose your insulin to cover those carbohydrates. And the journalist Ross says to his doctor, well, wait a minute, let me get this straight. You're telling me that because I have diabetes, carbohydrates are not toxic to me now, and insulin is the antidote. So you want me to eat the toxin and take the antidote? And wouldn't it be better off if I just didn't eat the toxin? Which is sort of the dietary approach to these perspectives, if there is a dietary solution to these disorders. But anytime you take a drug, so you can imagine, and again, I discuss in the book Rethinking Diabetes, the clinical trials that have been done through the 2000s, most notably by actually a San Francisco-based startup named Virta Health, that have demonstrated that type 2 diabetes in particular can be put into remission with dietary therapy. So particularly a ketogenic diet. You could also do it apparently with calorie-restricted diets, has been reported in England. I'm skeptical about the long-term effects, and I would love to see a trial comparing the two and sussing that out. But so you're diagnosed with type 2 diabetes. Again, now we're talking about 95% of the patients who are not, this used to be called non-insulin dependent diabetes, because you don't need insulin to survive. And you're told we're going to take two approaches. You can have a choice of two approaches. So the conventional approach is you're going to pretty much eat what you want, a healthy version of what you want: fruits, vegetables, whole grains, lean meats, nuts, sugar in moderation, meat in moderation, fish, chicken. And we're going to give you drugs to control the blood sugar and control the symptoms. So, oral hypoglycemics or GLP-1 agonists, or pick your poison for the blood sugar. If your blood pressure goes up, we have drugs for that. If you've had neuropathies, that's a little more difficult. Hopefully we won't have to amputate anything, but you never know. And if you start getting retinopathies, we have drugs and surgical techniques for that. They involve sticking needles in your eyeballs, but people get used to it. The alternative is we put you on dietary therapy and the disease goes into remission. And as long as you adhere to the diet, you will not manifest symptoms of the disease.
I'll choose the diet.
Now, you can't metabolize the carbohydrate content of the diet, so you don't eat carbohydrates, you replace them with fat. So it's a high-fat, very low-carb diet. It's keto for all intents and purposes. The VERTA trial demonstrated that dietary approach can put this disease into remission. So remember, the conventional thinking is that diabetes is a chronic progressive disorder that's only going to get worse. Dietary therapies trials, clinical trials, have demonstrated that it's not a chronic progressive disorder unless you eat a carbohydrate-rich diet. Okay, so the chronic progressive nature of the disease seems to be a response to the diet. And the point I make in the book is that the ketogenic diet was never tested until the early 2000s. It's now been tested there are more clinical trials testing keto for diabetes and other disease states in any diet, any other diet in existence. There's 200 trials or so that have been completed and probably another couple hundred that are in the works for virtually every disease state we can imagine. We know it's a benign trial in the short term. We know that it has some remarkable effects, including putting diabetes into remission. So when we talk about the drugs being beneficial, and clearly they are a disorder, I'm not putting down the whole pharmaceutical industry. I don't have the background or the understanding to even take that on. I could take on how physicians have thought about diabetes for 100 years. And I could talk about all the mistakes that were made. And I could say I can see those mistakes being repeated in the Ozempic story. Doesn't mean the physicians won't be right, that in jumping to conclusions about the nature of the disease from the effect of the drug or the apparent effect of the drug, they won't be right. But I can guarantee you that they're jumping to conclusions. And it's very dangerous in medical science to jump to conclusions, because after a while you forget that you had jumped, and these unproven assertions become accepted as dogmatic facts.